Acoustic neuromas, also known as vestibular schwannomas, are non-malignant tumors of the eighth cranial nerve. Most commonly, they arise from the covering cells, Schwann cells, of the inferior vestibular nerve. Only about 10 tumors are newly diagnosed each year per million persons, corresponding to between 2,000 and 3,000 new cases each year in the U.S. Another way of looking at this is that an average person has a risk of about 1 in 1,000 of developing an acoustic neuroma in their lifetime. In patients with hearing asymmetry, it is believed that only about 1 in 1,000 has acoustic neuroma, although some report prevalence as high as 2.5%. Acoustic neuroma occurs in two forms, a sporadic form and a form associated with an inherited syndrome called neurofibromatosis type 2. About 95% of all cases are sporadic. Diagnosis of an acoustic neuroma usually requires either a medical doctor with ontologic expertise who can integrate together the entire picture or an MRI with gadolinium. Patients with unexplained stable asymmetrical hearing loss should generally be evaluated by a medical doctor with ontologic expertise. Hearing loss is the most frequent symptom of acoustic neuroma, occurring in more than 95% of patients, about 90% present with a one-sided, slowly progressive hearing impairment. Clinicians often attempt to estimate the risk of an acoustic neuroma by looking at the pattern of hearing loss. A high-frequency sensorineural pattern is the most common type, occurring in approximately 2/3 of patients. In the remaining third, the next most common observation is hearing loss at low frequency. Even less commonly, some have the cookie bite pattern. Tinnitus is very common in acoustic neuroma, is usually unilateral and confined to the affected ear. Looking at things the other way, if you have tinnitus, it is very, very unlikely that you have an acoustic neuroma because these tumors are far rarer than other mechanisms of ear damage. In spite of the usual origin of acoustic neuromas in the inferior vestibular nerve, vertigo prior to surgery is not common, occurring in only about 20% of persons with acoustic neuroma. Vertigo is more common with smaller tumors. Unsteadiness is much more prevalent than vertigo, and approximately 70% of patients with large tumors have this symptom. Cerebellar symptoms are unusual. Hyperventilation-induced nystagmus is a little-known physical sign that may be far more specific for acoustic neuroma. Evaluation of HVIN requires more sophisticated equipment than is available at most offices. It also requires the examiner to be familiar with this sign and is somewhat obscure. Facial sensory disturbances occur in only large tumors, about 50% of those greater than 2 centimeters in size. Facial weakness is uncommon. Facial twitching, also known as facial stachnosis or hemifacial spasm, occurs in about 10% of patients. Headache prior to surgery occurs in roughly 40% of those with large tumors. About half of all acoustic neuromas are presently treated with surgery. This option will likely decline over the next few decades as use of gamma knife treatment grows. In most instances, surgical removal of the tumor is the preferred option because it prevents potentially fatal complications of tumor growth. Surgery may theoretically enable preservation of hearing, although it is very rare that hearing is actually serviceable after surgery. Usually the surgery is done at an academic center by a team of surgeons, including a neurologist and a neurosurgeon. There are several operative approaches. Translabyrinthine, through the inner ear. Hearing loss is expected and inevitable, not appropriate for very large tumors. Retrostigmoid or subacoptial, through the skull behind the ear. Retraction of the cerebellum, part of the brain, is necessary. Headaches are common after this approach. The middle fossa approach can theoretically preserve hearing, but like the retrostigmoid, the approach is intrinsically more dangerous as it involves retraction of the brain and also is more prone to complications. Compared to radiosurgery, the primary advantage of conventional surgery is avoidance of late complications associated with radiation effects on neighboring structures. Each of these surgical approaches has advantages and disadvantages that must be considered in selecting an optimal approach. Surgical treatment where the brain is exposed is always nearly performed by a team of surgeons, usually including a neurologist and a neurosurgeon. Most patients are admitted to the hospital a day before the operation. After surgery, they spend a night in a monitored unit. Most are discharged from the hospital within 4 to 6 days after surgery, and return to work is usually possible in 6 weeks. MRIs are usually obtained at 1 in 5 years to detect residual or recurrent tumor growth. Near total tumor removal is advised. Careful follow-up with MRI is advised to detect reoccurrence. Nodular or progressive enhancement of the internal auditory canal may represent regrowth. With respect to hearing preservation surgery, while of course it is certainly desirable, unfortunately the chance of hearing being preserved after acoustic neuroma surgery is slight. While hearing may be preserved immediately after surgery, it usually deteriorates in most within a few years. In most instances, acoustic neuroma surgery results in complete loss of vestibular function on the operated side. Patients frequently experience vertigo and imbalance post-surgery. Surgical treatment per se has a substantial risk. Overall, the risk of death from acoustic neuroma surgery is about 0.5 to 2%. Unexpected post-operative complications occur in roughly 20%, with more complications occurring in elderly and infirm individuals and those with large tumors. Complications ordered from rare to frequent are listed: stroke, injury to cerebellum, pons, or temporal lobe, death, about 0.5 to 2% depending on the center, CSF leak, 5 to 15%, meningitis, 2 to 10%, facial weakness, 4 to 15%, incidence of total paralysis. Tumor size is a large factor in this complication. Hearing loss risk immediately after surgery: translabyrinthine, 100%, retrostigmoid, 60%, middle fossa, 40%. Hearing occasionally improves for the middle fossa approach. Headache, persistent in 10 to 34%. Imbalance and dizziness. Almost all patients who have any vestibular function prior to surgery will have worsening of balance after surgery. This is not a complication, but a consequence. In review of 258 patients operated via the translabyrinthine approach, stroke or cerebellar injury occurred in 1.1%. Cerebellar injury can occur due to traction as well as due to injury to branches of the anterior inferior cerebellar artery. There is overall a 0.5% incidence of death due to acoustic neuroma surgery. Discharge to long-term care, 1.2%. To short-term rehabilitation, 4.4% are also possibilities. Thus, there is roughly a 1.7% chance of death or long-term nursing care being required after acoustic neuroma surgery. The odds are better if one chooses a high-volume